See our participant numbers going up. So let's see, we'll start in a little bit. All right, looks like we have 32 people in the room. That's great. Let's see if it keeps going. Otherwise, maybe we'll start. All right, I think we've let everybody in the room who was waiting. Let's see. All right, well, it is 7:02, so let's get started. We've got a very packed schedule, and I'm glad to see such a great turnout, especially for those of you who are on the East Coast in the US. It's early, it's 7 o'clock, and I see a couple names that I recognize. We've got a great agenda planned for you all. I want to say good morning, good afternoon, good evening to everyone. My name is Sue Wong. I'm the president of the World Hepatitis Alliance, and really excited about this NOhep Moms webinar that we have today. We're focusing on prevention of mother-to-child transmission of viral hepatitis with a focus on hepatitis B specifically. So today we'll be talking to you about NOhep's new Moms initiative and the ways you can add your voice to this global movement to have an impact. Our goal is to give our next generation a hep-free future, and we need all of you. We are delighted today to have Dr. Fumi Lacey from WHO with us, and she will provide a presentation to us on the recent guidelines from WHO on treating Hep B in pregnancy to reduce prevention of mother-to-child transmission. Fumi, as many of you know, is the hepatitis lead of the World Health Organization. She was previously regional advisor for viral hepatitis in the WHO Afro region, where she provided country support and oversaw the coalition of hepatitis strategic information and surveillance data in the Africa region. So it's a real big treat to have you here, Fumi. Thank you for joining us. And then we will have two additional amazing women, BC Bright and Lien Tren, who will share with us their personal experiences and the impact of PMTCT in their regions. BC Bright is a consultant clinical pharmacist. She's a lecturer, a psychologist, and public health manager. She's a woman of many talents. She is the first vice chairman and CEO of Live Well Initiative, LWI, a self-sustaining nonprofit healthcare social enterprise, which has impacted over 2 million Nigerians and thousands of Ghanaians with health literacy, improved overall health and wellness. Welcome, BC. And then we have Lien Tran, who is an epidemiologist and PhD scholar at the WHO Collaborating Center for Viral Hepatitis at the Doherty Institute in Melbourne, Australia. Her current research is on hepatitis B care and primary care. She's currently the WHA, World Hepatitis Alliance regional board member for the Wipro region. Welcome, Lien. And so just so you all know, we do have the chat open, so feel free to utilize this during the webinar to have a discussion or to pose any questions to the panelists or to fellow audience members. So next, we are going to showcase our NOhep Moms video, and I will have one of the staff will be helping us open that up. There we go. Oh, Chris, we don't have sound.
If they need it. Thousands of babies are born each year with hepatitis B, putting their health at risk. If we test all pregnant mothers, provide hepatitis treatment if they need it, and vaccinate their babies, we can stop hepatitis B shortening the lives of another generation. Join NOhep, and together we can win the fight against viral hepatitis.
Sorry, I was muted. Thank you. So if you go to our NOhep Moms website, which you see the link here, you'll see an array of excellent resources for the campaign. We have educational resources. We have some selfie pictures that you can upload your own pictures to create a message. We have this great infographic, which is educational, and women can use to advocate for the care that they need during pregnancy. And then we have an open letter for Gavi, which we really advocate all of you to join. And maybe Chris, I don't know if we can just put the link into the chat so people can perhaps just open it directly during our session. That would be nice. Okay, next, go to my next slide. Great. So and importantly, while this is a campaign focused on preventing mother-to-child transmission, we do need support from people who are not necessarily mothers themselves, but support moms and babies. So we need the spouses, the partners, the family members, and friends of pregnant women with Hep B to be supporters. And as we go through this webinar, I think you'll see how important it is, especially for women to have allies during pregnancy, because it is a challenging and vulnerable time, oftentimes. So to start our discussion, elimination of PMTCT, or mother-to-child transmission of viral hepatitis, is doable. We have the tools for testing, treatment, and vaccination to prevent transmission. Yet there are many gaps in care, and every year millions of babies continue to be infected. So modeling was done in 2016 by the Polaris Observatory collaboration, and they found that about 1.8 million children aged 5 years at that time were living with hepatitis B, and that's a prevalence about 1.4%. And in this day and age, this should really not be the case. We should be looking to eliminate transmission and reduce it to zero. And when you break it down as to where these gaps in care are, you can see that there are multiple levels of gaps that we see. So globally, we do pretty good with the 3-dose vaccination, but there's still a gap. So 87% of infants globally receive the 3-dose vaccination in the first year of life. When you look at before age 5, it's even higher. But for before age 1, there's still 13% gap. In terms of birth dose vaccine, which is within 24 hours, as recommended by WHO, it's less than half of babies worldwide who actually receive the birth dose. And then in terms of HBIG, which is not part of the WHO recommendations, but available in some countries, only 13% of infants receive HBIG along with a full vaccination regimen. And then in terms of women who have a high viral load that actually receive antiviral therapy, we think it's actually less than 1%. And so there's still a lot of room for advocacy. Next. So this campaign is very personal to me. I was infected with Hep B either in infancy or as a young child. My parents are from Taiwan and immigrated to the US. In Taiwan, my maternal grandfather was a dentist. My maternal grandmother was a midwife. We found out later they both had Hep B. And in Taiwan, it was very common actually before the advent of hepatitis B vaccination. I found out actually only in college myself when I had donated blood. It didn't really impact me at that time. I had no symptoms, and I was just starting to get medical care when I went into med school. So I went into med school, and I was very fortunate that it didn't impact my medical training at all through residency or getting a job. As we have heard from around the world, many healthcare professionals with Hep B actually do face much stigma and discrimination, unfortunately. So I met my husband, who you see here, and he got his Hep B vaccines. And this was actually, at that time, I was not aware enough one of my good friends who's an ID doctor said, you should make sure Dan gets his vaccines. And so we had him get his vaccines. And I'm very fortunate because he's been very supportive of me during this journey. So when I became pregnant, I was very concerned about passing Hep B to my kids, but I had the benefit of medical knowledge and medical care. I had my viral load tested twice during pregnancy, and it was not high enough to be at risk for high risk for vertical transmission, and so I didn't need any medications. In the picture you see here, this is us delivering my firstborn. And then during this time, I was actually working at a community health center developing a Hep B Moms program. And we developed this Hep B Moms roadmap, which as I was developing, it was interesting just because I was following it myself too for my own pregnancies. And it was an easy infographic for women to be able to bring to the L&D, to the hospital, even if they didn't feel comfortable telling the staff themselves, they could at least provide this information just in case the information had not been relayed from their OBGYN to the hospital. So we ended up having 4 kids, and my husband's job during anytime I went to the hospital to deliver, he knew that his job was to make sure that each of our kids got their vaccines within 12 hours of birth. Because usually the mom is very tired and groggy from labor. So I really relied on him to do this. And we did it 4 times, so he got the hang of it. Each kid completed their vaccine series at the pediatrician's office afterwards. And as a mom, I'm really relieved to know that they're all Hep B free and immune. They don't have to spend their lives worrying about having Hep B. They don't have to get checkups like I do. And they don't have to worry about being a source of transmission or being at risk of liver cancer. And so this success story is really what we should be aiming for all women. And this is why I am a mom fighting hepatitis, as you see in this selfie picture. All right, next slide. So, but I want to contrast my experience with the struggles that many women actually have faced with living with hepatitis B around the world. And these are just some statements and personal stories that we've heard from around the world. And this is from the Hep B Foundation, which has worked with many, many women around the globe who face these issues. And on the left, you see there's so many issues with stigma, discrimination, even intimate partner violence. Women worrying that they can never get married because nobody will accept them. Feeling like this is the end of the world. It's like a death sentence. There are a lot of people who actually contemplate suicide because of their diagnosis. On the very bottom left, you see a woman whose husband's family wanted her to abort her child. And her husband basically emotionally abandoned her, stopped talking to her. And she just felt very lonely and didn't want the abortion. She actually wanted her child and wanted to be cured. And on the right, there's a lot of lack of information and lack of access to the services. And what we find is a lot of women are not aware of what they need to do. And when they find out that they are at risk of transmitting, they become frantic and desperate to protect their babies. And in areas where there is not birth dose, sometimes they use the pentavalent vaccine, which is not recommended. But when they don't have access, this is what happens. And you see that there's just, it's not as readily available in some countries as it is in other places. And you can just see here, there's just this, the mom's wish is that their baby is safe from this virus. Next. So, and then we are obviously in the time of COVID, and there's a lot of concern over what its impact is on PMTCT and viral hepatitis elimination in general. And there was a recent modeling study done by Imperial College London that basically showed what's interesting is that anytime there's been social upheaval or war or major calamities in a country, you will see that there is actually impact on vaccination services and that outbreaks such as measles have erupted when there's delays in vaccination. So we expect the same is happening with Hep B as well. And in their modeling, when they project the worst case scenario with high levels of disruption, meaning that birth dose overall is reduced by 60%, childhood vaccinations are reduced by 20%, plus with the delay of slow recovery of vaccine expansion, with things coming back up, people being reluctant to utilize healthcare services, we believe that it's projected that there could be additional 5.3 million children with chronic hepatitis B infection for those born between 2020 and 2030. And from these additional infections, we're looking at an additional 1 million in additional deaths from Hep B from these children due to liver cancer as they get older. So this is a real tragedy, obviously, since we were trying to get to elimination by 2030. And so potentially, if we don't pick up on these gaps and don't really accelerate Hep B birth dose delivery, we are looking at, having a real delay in regression on the advancement that we had actually achieved towards elimination. So I think this is a really timely discussion for us to be having. So I'm going to pass this over now to Fumi to talk about the WHO guidelines, and then we'll go into our discussion. Thanks.
Thank you very much, Sue. And before I get started, I'm going to have to say a big thank you to World Hepatitis Alliance for organizing this meeting and the NOhep Mom. I'm going to talk about the prevention of mother-to-child transmission of hepatitis B and look at the guidelines on antiviral prophylaxis. And I have a very short time, and I want to address 4 main things in this short time. One, the outline will be an introduction and background to hepatitis B, which Sue has actually provided. I'm going to talk about the important role of childhood vaccination globally and where we are now, and talk about WHO guidance on PMTCT and antiviral therapy. And finally, I'm going to talk about how do we translate this to action. What is the implementation strategy or the considerations? So next slide, please. Okay, do I get the next slide? Okay, thank you. So hepatitis B is really a disease of global importance, and it has been underestimated for decades, mainly because of the long duration of the disease and the fact that it would require 20 to 30 years to lead to morbidity of liver cirrhosis or liver cancer. It has come again to the forefront because of the huge burden of the disease globally. As you can see, there are an estimated 257 million infections globally. It's come to the forefront because of the large burden, because of the rising death rate of viral hepatitis B and C. And this is in contrast to the declining death rate of many other infectious diseases. And we do know that hepatitis B and C accounted for about 1.34 million deaths in 2016. Another important reason why hepatitis has become topical at this point is because of the technological innovations that make the diagnosis and treatment possible. As you will see on this slide, and this is an interesting slide that shows the global burden according to various WHO regions. You would see that the highest burden area is in the Wipro region, and this blue is China and Mongolia. The second most prevalent or highest burden is in Africa, with an estimated 60 million people that have hepatitis B. And you would see the figure for Southeast Asia, Eastern Mediterranean, Europe, and the least prevalent is in the Americas. Next slide, please. So this slide shows the prevalence of hepatitis B in the general population by WHO region, as I have said. And you would see that on this slide on the left, all of the areas that are in deep pink, deep red, have a high endemicity greater than 8% of viral hepatitis B in the general population. And this leads us to transmission. And I really need to put a word in on transmission because there are many myths and many fallacies about transmission, all of which are correct or all of which are wrong, depending on which side you are at. So in highly endemic areas, the transmission occurs primarily perinatally or in early childhood. And that is why there's a focus on birth transmission and on preventing that. In areas of low seroprevalence, most infections can occur in adults, especially among persons belonging to defined risk groups. Next slide, please. Okay, so there's a delay in slide transition. Can I have the next slide? Or should I move the slides if you give me the control? Hello?
Umi, is this the right slide?
Can you hear me?
Where it says she was found to test positive. Is this the right one you're looking for? Umi?
Hi, everybody. Can you hear me?
Yes, we can hear you. Do you see the right slide now? Oh, we see you now too.
Okay. Okay, so very quickly, this is an interesting case, and I'm just going to use this to illustrate some of the things I'm going to talk about. This is Jane. She's 32 years old. She was found to test positive for hepatitis B surface antigen during pregnancy. And you know, she was quite concerned because she knows that hepatitis B is a risk to both the mother and the newborn. So Jane knows about mother-to-child transmission. She knows that hepatitis B leads to liver disease and liver cancer, and she's concerned about the socioeconomic and the emotional upheaval that comes from having this infection. She knows that the risk to her newborn is important. She knows that newborns tend to have chronic infections and can rapidly progress to liver disease or cancer. She knows that they are reservoirs of infection to other siblings, and she has heard that there might be a risk of vaccine failure. What is clear to her is that 90% of exposed infants become chronically infected compared to 5% of the exposed adults. And she went online and saw this table on the right and saw the vertical transmission rate, where they compared no interventions to interventions. And there are two categories of hepatitis B positive women: those who are E antigen negative and those who are E antigen positive. And she was informed that those who are E antigen positive have a higher risk of transmission to their newborns than those who are hepatitis E antigen negative. So the question is, how do we manage Jane? How do we counsel? How do we advise Jane? You are a HEP mom too, or you are in the community. What do you do with Jane and how do you support her? And that is what we're going to quickly go through in the next few minutes. Can I have the next slide? Can I have the next slide, please? Right. So in 2016, the World Health Assembly recognized that viral hepatitis is a real public health threat, and they endorsed the global health sector strategy for elimination of viral hepatitis as a public health threat by 2030. And on this slide, I just want to highlight three important things. So the global sector strategy sets ambitious targets to reduce new infections of hepatitis B and C by 90%, I mean, specifically 95% for B, and also to reduce the death rate by 65%. The second important thing from this table is that they have proposed a paradigm shift in the way we manage viral hepatitis, and that is to go through a public health route and change the way we think about viral hepatitis and liver disease. And thirdly, they've identified 5 core interventions, which if taken to scale will result in the defined elimination impact. Now, these five interventions are shown on this table, and those in red I want to highlight, and they're about preventing hepatitis B. We're talking about the 3-dose hepatitis vaccination, and we're talking hepatitis B PMTCT, which includes birth dose and others. The target of these interventions, these two interventions, which we'll focus on today, is for 2020, last year, the 3-dose vaccination coverage globally should be 90%, while the hepatitis B birth dose globally should be 50%. At these levels, the global prevalence in children under the age of 5 years old and 5 years old will be less than 1%, while the 2030 goal is 90-90 for both interventions, and the proposed target is less than 0.1% prevalence in children age 5 and below. Can I have the next slide that will show us where are we now with vaccination? So currently, the 3-dose vaccination, which is oftentimes pentavalent, has been implemented in all countries. And the challenge that stands today really is the coverage of these interventions. On the left, you would see that before the year 2000, where the 3-dose series was generally available, the global prevalence of hepatitis B in children under the age of 5, which includes newborn age 1, 2, 3, 4, and 5, was 4.7%. And you'd see the red hot areas of this map. On the right map, we see in 2017, something major had happened. The prevalence in these children had declined to 1.3%. And spots that were previously red hot have pretty much disappeared to an amber yellow. So something had happened. Many countries that were very high endemicity, more than 8%, had actually become lower. What made this difference? And that is where the vaccination comes in. Next slide. Okay. So many high endemic areas became intermediate due to effective vaccination. And I showed you that China and Mongolia moved from highly endemic to low endemicity in children. This is the picture in 2019. The global prevalence in children less than 5 years old and 5 years old had reached 0.94%, and the Sustainable Development Goal target had been met. So I think we will celebrate that the world as a whole is working well towards reducing hepatitis B transmission. But as you can see, there are some yellow areas that persist in some parts of WIPRO and AFRO. And AFRO failed to reach the less than 1%. The prevalence of hepatitis B surface antigen remained about 2.53 in sub-Saharan Africa. Additionally, the birth dose vaccination globally reached the level of 43%, but it remained 6% in the sub-Saharan Africa region. So there's a huge disparity of birth dose administration in Africa and some parts of WIPO compared with the rest of the world. So next slide, please. Okay, so I like this slide. This is really interesting. And it looks at burden of chronic hepatitis B infection in children and in adults. The panel on top talks about the burden in adults. So we have WIPRO having the highest prevalence or highest burden, and the region of Americas having the lowest burden. Now, if you look below, you would see in red the burden in children. So look at WIPRO that has the largest burden of disease, having the lowest burden in children under 5 compared to the Africa region, compared to Southeast Asia, where a lot of vaccination has been going on. Next slide, please. So in WIPRO, there are about 365,000 children with viral hepatitis. In Afro, the number is 4.3 million people. So what is WHO doing? What are the guidance for viral hepatitis control, viral hepatitis elimination? On this slide, I have identified 4 WHO guidance, and one is the position paper on hepatitis B vaccination, which was released in 2012 and 2017, and talking about all children or all infants should receive the first dose of hepatitis B vaccine as soon as possible after birth, preferably within 24 hours. The second is the WHO guidelines for prevention, care, and treatment of persons with chronic hepatitis B infection. And this advocates the use of tenofovir in selected people who meet up with that criteria. In 2017, there's a WHO guidance on hepatitis B and C testing, and even the HIV guidance talks about hepatitis B. So tenofovir is well recommended for treatment, but no recommendation was made on routine use of antiviral treatment as prophylaxis for pregnant women. Next slide. So why are we now talking about antiviral therapy? And there are 3 main reasons. And the first is there's a concern that the timely birth dose alone may not be sufficient to reach the hepatitis elimination goal of new infections in children at the level of 0.1% prevalence by 2030. And this is more so amongst infants born to hepatitis B infected women. There's also new evidence that has become available. That is new research evidence on the effectiveness of tenofovir in this group. Of course, there are requests from regions and countries in the context of triple elimination of HIV, syphilis, and hepatitis B to prevent this transmission. Next slide, please. So very quickly, I will highlight some of this evidence. I will not go into detail, but the evidence shows very clearly that the drug tenofovir is safe and is efficacious in pregnancy. The evidence also shows us that the performance or the identification of hepatitis B E antigen can be used as an alternative to hepatitis B DNA to assess the eligibility for commencing prophylaxis during pregnancy, and also to help us define the threshold for initiating this therapy. Next slide, please. Okay, so these are the guidelines. And it was released in 2020, last year, just ahead of World Hepatitis Day. There are 4 major steps to this antiviral guidelines, and I'm going to spend a few minutes just trying to unbundle what this is. So the first of the steps is on the next slide, please. All right, so it's all about testing. So this is serological testing in pregnant women. And the recommendation right now is all pregnant women should be tested for HIV, hepatitis, syphilis, at least once and as early as possible in pregnancy. And of course, testing, there are 2 outcomes. They're either positive or negative. Now the step 2, next slide, please. So this test 2 is about assessment of the positive patient or the positive woman. She's really not a patient, she's a pregnant woman. So the next step is doing a DNA viral load test or hepatitis E antigen test to determine if she meets the criteria for prophylaxis. And of course, there can be 1 of 3 outcomes. If a pregnant woman or any person for that matter who is hepatitis B surface antigen has evidence of cirrhosis, on clinical examination, on fibroscan or any form of assessment, then these are people who require treatment. For women requiring prophylaxis, where the DNA level is hepatitis B DNA level, exceeds 200 international units per mil, or where the person is HBe antigen positive, then these are women who may qualify for treatment. So stage 2 is assessment stage. And stage 3, next slide, please. Okay, so stage 3, the recommendation is women who are testing positive for hepatitis B infection with a DNA exceeding our cutoff mark should receive tenofovir prophylaxis from 28 weeks of pregnancy until at least birth to prevent transmission of hepatitis B from mother to offspring. Those women who are E antigen negative or who do not have cirrhosis or who have a low viremia, there is no requirement for maternal prophylaxis, and these women should receive follow-up, and maybe after pregnancy, they can be referred to the hepatitis clinic for follow-up. And of course, if they have cirrhosis, either clinically or from fibroscan assessment or any other fibrosis assessment, then they require long-term therapy for their own health. Next slide, please. Okay, and finally, the fourth step is the infant intervention. And the infant intervention is the hepatitis birth dose vaccination of the infant, followed by the usual EPI series of pentavalent of 2 or 3 doses. And these are usually given at 6 weeks, 10 weeks, 14 weeks, depending on the country. And the recommendation is long-standing. All infants should receive their dose of B vaccine as soon as possible after birth. The birth dose should be followed by 2 or 3 doses to complete the primary vaccine series. We do recognize that the hepatitis B vaccination series confers over 95% protection to the child for getting hepatitis B. Here is hepatitis B immunoglobulin, which, if available, it's a proviso for infants born to hepatitis B surface antigen positive mothers, especially if they are E antigen positive or if they have a high DNA. And this is the case because these women have been associated with failure of immunoprophylaxis. So specifically, surface antigen positive women with E antigen positive or with high DNA. Next slide, please. All right, so back to Jane, and the question is, how do we evaluate Jane? Do we reassure Jane? Do we provide how we care? I think what we need to do is take Jane through these 4 steps. Of course, Jane already has gone to the first step. She's been tested, she's been found to be positive, all right? So on assessment, Jane was found to be E antigen negative. Jane was found to have a viral load that was low. For instance, her viral load was 200 international units per mil. So my question to the audience is, what should we do for Jane? Do we put Jane on tenofovir prophylaxis? Or what do we do? And that is really a good question. And I would like some answers in the chat to reassure us or to reassure Jane or link her to care which is required. Thank you very much. Next slide, please. So having said that, next slide. What will a successful national level PMTCT effort look like? For many years, for nearly 2 decades, I've worked in a teaching hospital and maybe was not involved with national program efforts. So the question though is, where there is a national level program, where this activity is done at the tertiary center, at the secondary care, is done in the primary healthcare center, is done in the community, that is a national level effort. So for these to happen, we need a high ANC neonatal care coverage, And of course, there are interventions in both the mother and the infant. This slide is really summarizing part of what I've said and what will it take to get us there. So in terms of the mother, we're looking at screening, we're looking at linkage to management and antiviral drugs. We're looking at birth dose minimum requirement, birth dose and 2 or 3 hepatitis series in these children. In some high-income countries where they have routinely given birth dose for the past 20 years, they sometimes may add hepatitis B immunoglobulin, and in some countries, they actually would follow up this child. So if you look at the bottom of the slide, we've listed there some of the considerations we must think through before we set up a program. And of course, one is cost. Somebody has to pay for testing of mothers. Somebody has to pay for training of healthcare workers. Somebody has to organize the information system to capture all of that data and many more in a systematic and organized way. Those are things that a program must do. Currently, WHO is working on establishing the criteria for validation of PMTCT of hepatitis B. To simplify that, we all know that last year or 2 years ago, many countries, especially Africa, was certified polio-free. So if we can understand the context of polio-free, we can understand the context of validation of PMTCT. Next slide. And in the last few slides, next slide, please. Right, so what are the general implementation recommendations or thoughts? It depends on where you are. It depends on the national vaccination status. If you are in North America, where hepatitis B birth dose and the series have a coverage of greater than 90%, you have a different challenge from when you're in Africa, where the hepatitis B birth dose is only in 13 countries, where the coverage is only 6%, where there are no national programs for PMTCT. So it will depend on the prevalence of where you are, and then the prevalence in 5-year-olds and the population. We need to look at the service coverage of immunization. What about the affordability and availability of testing and prophylaxis? Now, this table on the right shows that usually it's an incremental approach to preventing infection. I think I must have gone on for a bit, so I'll quickly summarize. The key takeaway from this slide is universal immunization of hepatitis of infants, including the timely birth dose, is the foundation of programs to prevent hepatitis B infection. So in high endemic countries such as sub-Saharan Africa, with suboptimal coverage of infant hepatitis B vaccination, the priority will be to increase the coverage of birth dose for the greatest bang for our bucks, greatest impact at the lowest cost. In other countries where this has been established, then they go on to prophylaxis and immunoglobulin if available. Next slide, please. And as I round up, implementation of antiviral prophylaxis, other factors include the triple elimination of HIV, syphilis, and hepatitis B. Right now, in many parts of the world where there's HIV, a PMTCT program for HIV and syphilis has been well established. So in terms of practical provision of services, it is possible to leverage hepatitis B screening and testing in PMTCT in these programs that already have an established infrastructure. Some challenges will be in terms of diagnostic testing, the context of universal healthcare, the quality of the kits and the test, and the availability of treatment. Next slide, please. And last slide. All right, so in conclusion, amidst the world affected by COVID-19, viral hepatitis remains a major public health threat. We have the tools, we have the strategy for elimination. We can prevent liver cancer and save lives if we act now. However, government leadership is pivotal to providing that environment that is enabling for collaboration with different partners. It's important to mobilize funding, to train, and successfully implement specific responses. And of course, the community advocacy has a big role to play. And always I like to think big, even as we start small in our communities, but it's important to start right now. And on that note, on the last slide, I just want to acknowledge all of the people that have made this successful. I thank you very much. I thank Sue Wang and I thank World Hepatitis Alliance. Thank you very much. Over.
Great. Thank you, Dr. Lacey. That was very, very informative and really helpful to have somebody from WHO walk us through those guidelines. So thank you. So I want to, without any further ado, bring in our panel, Leanne and BC. Let's start this and talking about what is the experience of mothers in your regions. And Leanne, for you, if you want to talk about the different, you work and live in Australia, but you are Vietnamese. If you want to kind of contrast and compare the two regions, I'll let you start.
Thank you for me for the brief, and yeah, thanks, Sue. I think, yes, I think that I have that kind of like luck to actually experience the two very different health system in the care for women living with hepatitis B in like prevention of mother-to-child transmission. So I think the two things that two countries share is that there's already a set of policies and funding available and guidelines available for prevention of mother-to-child transmission. But to be honest, having a policy or all kind of support in place is just like the starting point of getting it actually implemented. So I think more or less like you to be lucky while working in the health sector while you were pregnant with the kids. I was lucky to when I had both my child delivered in Vietnam, but by that time I was lucky because I was engaged with the health system, and then I received like proper care. So my kids had like immunoglobulin and vaccination, and they are fine. But actually, like in the same time, like a close friend of mine, like living in the same city, not very far from me, and she was pregnant, like by the time I was. But like, look, the policy is there, the guidelines was there, but she did not receive that like Hep B testing during her pregnancy. So that day she just called me like panically, like, look, I'm 39 weeks pregnant and I just went to the hospital to register for my delivery, and they got me tested and I was Hep B positive. So I guess so like having it there is one point. So we need to make sure that it goes to the community, to people actually know about that. So that's a point. There's another thing that Australia and Vietnam share is the stigma and discrimination against people living with Hep B in their community. And because of that, people like try to avoid getting tested or try to avoid getting the information disclosed to family members. In Australia, especially in Victoria, the state that I'm living and working at the moment, that's like one of the healthcare system that I can say that I'm proud of in many cases. But in recent years, it did happen that there has been case of mother-to-child transmission of Hep B in Victoria. So that's really sad. Even like with all the funding, all the policies, all the guidelines, and all the health promotion, everything that still happen. So I just want to hear more.
Yeah,
And and there's also one thing that I want to flag as well, that information from the WIPRO office. So they did a like for the WIPRO region, they did an estimate and it showed that from 1990 to 2014, hepatitis B vaccination already averted 30 million cases of hepatitis B and 7 million deaths due to Hep B. So Hep B vaccine really worked. And we just need to make sure that it's not only the policies, not only the guidelines, but it needs to come to every family, comes to every woman.
great. Thanks, Lan.
Yeah.
Those are some really important points you bring up. I'm going to go over to BC, and why don't you tell us how things are in Nigeria and in your community?
Yes, thank you. Hello, everyone. It's a privilege to be here. I want to talk about maternal to child transmission of viral hepatitis. It's actually second um, only to Asia. In the whole of the sub-Saharan Africa, the maternal to child, mother to child transmission of viral hepatitis is only second to the prevalence in Asia. So it's a real big disease burden in Africa, in sub-Saharan Africa. Now, looking at the Nigerian experience, we run the Women in Hepatitis Africa initiative, and the Women's Wellness Center for Hepatitis is actually located in a very low income suburb. And we do have a full team of practitioners, and we usually embark on screening. I look through the algorithm related by Professor Leshi. We usually go through the screening using the RDT, and then if a woman tests positive, because we run the antenatal clinics and so we have a rule that every pregnant woman is screened. We usually refer them to the hepatologist because we do have a hepatologist that works with the non-profit organization. So it's a real disease burden, and it is true, like Lynn said, the stigma problem is there, and the challenges are there. But we have found from our own experience that the women are very amenable, they're very much interested in learning. And one thing we've discovered is that even the low-income women, they are really interested, and we have this training program which we call the Women Champions in Hepatitis training. And we believe that if you empower a woman, you're empowering a nation. So we teach the women what viral hepatitis is all about. We teach them what vertical transmission is all about. And so once we've trained them, we expect each woman that has been trained to form a cell and train other women, irrespective of the level of literacy. So we have trained professional women. We've also trained very low literacy women. We've trained community leaders who are women. And in one of the low literacy communities, the men actually offered to join because they found that it was very enriching. And you know, when it comes to health, the men also make a lot of decisions as regards to women. So the challenges are there, but we are selling smoothly so far with the low literacy women. And the major challenge we have, of course, is funding, which is a global challenge. I don't think there's any funding anywhere for hepatitis. But on the whole, we have a lot of cooperation from the women. We work with the local government and the Lagos State Primary Healthcare Board. And so when it's time to immunize the babies get their immunization. Now, the first dose vaccine, according to statistics here in Nigeria, the government has 51% coverage, which is still in line with the global coverage so far. And I can see from Professor Leshi's paper that by 2030, they hope to have the 90% coverage of first dose vaccine. So I would say we're not doing too badly. Now, how do we manage that in the low income, low literacy area? What we do is that the Traditional birth attendants are the ones that take delivery for these women who are so too poor to go to the health system. But we try to encourage them to still patronize the health system. And what the government does is they also recognize those traditional birth attendants by teaching them who to refer to the health system and so on. And so what we do is that any baby that is not born in the government health center, we encourage them to go to the government health center by offering them free antenatal services, free medicine, and everything free. But we then encourage them to go and have your baby at the government health center. But if they don't have the baby at the government health center, they have to go and get the vaccine within 24 hours, and then they do the 6 weeks, 10 weeks, and 14 weeks follow-up. So the birth dose vaccine is very important, and then they thereafter go for the pentavalent at 6 weeks, at 10 weeks, and 14 weeks. So the women are very cooperative. I find that they're very cooperative. We actually have a poster similar to the poster behind Sue and Lian, which we took with our women. I would have used that poster as my background if I knew. So we are getting along quite well with them, but the algorithms need to be put in place where the women will be encouraged, will be screened right from pregnancy. That is very, very important. And if they are positive, especially for the E antigen, which we cannot do, once they're positive with the RDT, we refer them to the health system or to the hepatologist. And if they're positive, then they may need to be placed on tenofovir. Occasionally, when they're placed on tenofovir, we help with supplying their medication. That's as far as we can go. So I would say the challenges are there, but they are not unsurmountable. Now, for stigma, it's a major problem, and we are trying to overcome the stigma. And what we do with that is to empower the women. In the first place, we train their leaders. You know, I told you we train some of the women leaders. So that kind of destigmatizes the whole concept of having living with viral hepatitis. And then we also have, among the champions we train, we have an organogram for the champions. So if a champion is trained and that person trains at least 10 other women, then we promote that champion to a supervisor. And she can join us in training other women within her literacy bracket. And if she does well as a supervisor, we promote her to the faculty, to the training faculty, so there's an incentive for the women. And so they don't think of the stigma so much. In fact, there was an open market where one of the market leaders who was found to be positive came out and openly declared to her colleagues in the market that she was living with viral hepatitis and nobody stigmatized her. Number one, she was already a leader. Number two, she was teaching them about something they didn't know about. So we are empowering the women, we're encouraging them, and we are working with the government and with the health system. So although there are challenges, they are not unsurmountable. That's what I'll say for now. Thank you.
That's great, BC. I love that idea of empowering these women and then having them empower more people. I mean, you're creating a movement there with that. So I just love hearing these examples. So let's turn it over. We're running out of time. We are going to go about 10 minutes over just so we can talk about the one next topic. This is being recorded, so those of you who have to go and need to, want to listen later, we'll have the recording posted. But let's turn to talking about solutions. What can we do for somebody mentioned this in the chat, policy is obviously really important, making sure testing is offered to all, the birth dose is a standard policy as well. What can we do as moms in demanding action? And then Fumi, if you want to also bring up, what are some other things we had talked in preparing this about diagnostics, having rapid diagnostics for surface antigen and viral load, us advocating for those things to be approved. Those are all really important. But I want to see what, Leanne, BC, and Fumi, what you guys all think would be great for us as community members to do in terms of getting to some solutions.
Is that directed at me or Leanne? I thought you.
Oh, you or Leanne, either one of you guys.
Okay, I don't mind going, since Leanne is not on muted, I could go quickly into the solution. The first solution I would suggest is that I think there should be a global policy to screen all pregnant women for hepatitis B. It should be a routine screening. You know, when pregnant women go for their antenatal, they screen them, check their blood pressure, check their vital signs. We should globally accept that hepatitis B screening should be regarded as one of the universal screenings for pregnant women. I think that is a starting point. Secondly, I think that any pregnant woman that is found to be positive for hepatitis B should automatically be screened for the E antigen, so that if she has the E antigen, then we know that she might be able to transmit this vertically to her baby. And so she should be commenced on tenofovir from 28 weeks. I think that should also be a policy. And then another policy, another solution is that all infants should be vaccinated with the hepatitis B um, birth dose vaccine within 24 hours of birth, not delaying it till. I know some countries would say ideally give within 24 hours of birth, but you can give up to 2 weeks after birth. But I think the 24-hour window is very important, and most countries should try to adhere to that. And then the subsequent pentavalent doses at 6 and 10 weeks at least, if they don't want to do the 3 doses, then 6 and 10 or 6, 10 and 14. I think those should be policies, and I think that Gavi should be brought in to help support these policies globally, especially in low and middle income countries. And last but not the least, I want to recommend very strongly that patient organizations should try and key in with what the IAPO is doing. I'm actually on the board of IAPO. And IAPO has instituted what we call the World Patient Safety Day. And this year in particular, they're looking at safety to mothers and new babies, neonates, and so on. So there's so much emphasis on the safety at birth. And that process of birthing makes a lot of difference when you're talking about hepatitis B. You can have either vertical or horizontal transmission during the process of birthing and just after birth. So the IAPO is emphasizing that safety of both mother and baby should be brought to the fore. I'll invite everybody on this forum to please, as the conversation goes on, along with the World Hepatitis Alliance, to also key to what the Global Patient Alliance is doing. And I want to say that hepatitis B or C does not have to be the stigmatized issue. Hepatitis is something that people can manage with and live with if it's B, and if it's C, it can be cured. And then whether it's B or C, it can be very well managed, and people can have a very healthy life devoid of stigma and devoid of anything negative. So thank you very much. Thank you.
That's a great message of hope, BC. Thank you. Leanne, do you want to add something?
Yeah, actually, I really want to emphasize two things, like integration and coordination. That's going to be like at two different levels that I will explain a little bit later. So that's also from a global level, and also from like the cells of the society, like family level. So at global and policy level, I know we like this decade is the decade of elimination. So a number of infections are also like having the same elimination goal as we are having with hepatitis. I do not want to sound greedy, but funding for hepatitis B is like insignificant, and there's no global pot of funding to fund global activities for hepatitis, except the NOhep fund, which is like just newly established and not that full of money as other one like Global Fund or other funds. And the same thing, I do not want to be greedy and do not want to like try to advocate to pull money out from anyone, because policymakers, governments keep talking that this is this much money that we have. So like what needs to be done in that pot of money that's already there. So that's like integration and coordination. We work together with different like sectors to make sure that we deliver the services that people need as well. People would want to be considered as a person with different health needs, but not just like a condition. When I'm going to a health service, I do not want to be seen as a person living with Hep B. I want to be seen as a mom, as as someone who wants to care about my mental health, my Hep B, and all sort of things. So for prevention of mother-to-child transmission for Hep B. So that's the story of reproductive health, of maternal and child health, and everything that need to come in together. And also like down to like personal, family, and individual level. So just make sure to make the responsibility of prevention of mother-to-child transmission of Hep B not of the moms only. Hep B is a family business that should be seen as the responsibilities of the whole family. In Vietnam or in China or in some Asian countries, I know that kind of guilt, that kind of like heavy responsibilities that the women feel when they are already really tired of being pregnant. So they lived with the fear of being blamed, of transmitting that to the kids. So I think that support from everyone in the family, including husbands, extended family, from the mom's families and from the dad's family, that would help very much, especially like a person like bearing a baby inside her body is already a big job. And then putting on another like pressure on her, like all of kind of blame, the guilt that she'll be receiving is unfair, and it's not her only job. Like I was really happy to see like how your husband helped with making sure of the vaccine. Yeah. I want to see that being done in all others' family.
Yes.
So thanks, Sue, for setting that example.
Point, Leanne. So even if you're not a mom, if you know a mom, if you love the mom, if you care for the baby, then this is also your business, right? To support the mom and her baby during this time. And we really need as many allies as possible. This is not just a hepatitis issue. This is not just a maternal child health issue. This is an important family issue. And so we really count on all of you who are here to help spread that message. Yeah. So and we also, only have a couple minutes left. Sorry.
So I think I just want to add the last point. That's also the human rights issues for the kids. They have the right to be free of a preventable disease.
Yes, I like that too. Thank you for bringing that up. So we're going to have to close. I just want to make sure everybody realizes that we are doing a really big push to ask Gavi to follow through with their commitment. They had said last year that they were going to cover birth dose as part of their remit, but they have yet to do so. They've actually delayed it because of COVID. We don't think that's acceptable. We think that they should follow through because during COVID, this is when we need it more than ever. So please today get on the website and add your list. We're trying to get to 300. I think we could get to more. I think we're only at 160 signatures at this point. So all of you who are on, please add your names so that Gavi actually sees that this is a big issue. Chris, I'm going to turn it over to see if there's anything else you want to bring up with the campaign. Chris is our communications director at the Alliance.
Thanks, Sue, and thanks to the whole panel for that really interesting discussion. So as Sue mentioned, we're running this NOhep Moms campaign, and the campaign's really there to bring a human face to the need for PMTCT services globally. So there's a few things you can get involved with on the webpage. We have a selfie tool, so you can upload your own selfie and post on social media to show the global community that's fighting to eliminate viral hepatitis. We also have a infographic, which is for pregnant women to explain to them the processes to go through to receive the services so they can be empowered with the knowledge to ask for services from their medical provider. As Sue mentioned, we also have the letter to Gavi, the Vaccines Alliance, asking them to join us in the fight against hepatitis B. So the Gavi board are meeting in May, and we're really looking to get as many signatures as possible on that letter so that we can write to them to urge them not to wait to join the fight to eliminate hepatitis B. All of these posters are translatable and adaptable, so you can use them on your local settings as well. It's all available on our website at nohep.org/mums, so we hope that you can all get involved. Back to you, Sue.
Great, thanks, Chris. And if any of you who are in the audience have any ideas or feedback, we are very open to this. And if you have ideas that we can share about how you've implemented this campaign, we would love to feature it in our social media. So thanks again to our amazing panelists. Thank you for spending your time, sharing your stories and your knowledge. Thank you for all of the audience members who came. We really appreciate the hour plus that you just spent with us. We'd love to work with you all more and engage with you, so do not feel shy about reaching out to us. And we will have this recording posted and the slides available as well. All right, take care, everybody, and here's to a HEP-free future for our next generation. Thank you.
Thank you, everyone. Bye-bye.
Bye-bye.
Thank you. Bye.